I think you can start recording after when the meeting starts, Nikhil. So, good evening, everyone, from SAT Hospital, Department of Neonatology, Government Medical College, Trivandrum, Kerala. So today we are going to have a seminar on the recent guidelines that came out in IP on March 2022 on the surveillance for developmental dysplasia of the hip in India. So there have been several guidelines which came out in 2019 by the American Academy also. And so we'll see what is different in the Indian guidelines, and we'll stress on the importance of screening and before discharge from the hospital, and not only in the newborn period, but also during infancy and early childhood also, to prevent long-term disability. So we are very fortunate to have an expert faculty also to give his views. Dr. Vinod Krishnan, he's a specialist pediatric orthopedic surgeon who is from the KIMS Health in Trivandrum itself. So sir has also kindly agreed to join us, and he will give his opinion at the end of the talk. So inviting Dr. Meghna Nema, who is our first year DM neonatology resident, to start the seminar. Over to you, Meghna.
Yes, ma'am. Thank you, ma'am. Good evening, all. Today we will be discussing on guidelines surveillance for developmental dysplasia of hip in India, which was recently been given on March 2022. So the overview would be, we will be discussing introduction with incidence and risk factors, clinical and imaging features, clinical tests which are being recommended by the guidelines, recommendations as per the age of the child, and what are the limitations of these guidelines. So this is the guidelines which was being published as clinical practice guidelines in the Indian Pediatrics Journal that we will be discussing. So the justification for this guideline was that DDH, when diagnosed during infancy, the conservative management is often successful with good long-term outcomes. In India, DDH is often not diagnosed until walking age, and there are limited guidelines for its screening. So these guidelines came with their objective to enhance early detection rate of DDH in India through developmental and implementation of a standardized surveillance care pathway, thus reducing the burden of late presenting DDH, as well as to help healthcare providers detect most cases of DDH before walking age and ideally before 6 months of age. So in short, the recommendation was routine clinical hip examination must be performed on all infants at birth and during immunization visit at these approximate time points like 6, 10, 14 weeks, 6 months, 9, 12, 15, and 18 months of age, which corresponds near around to our immunization visits. So a short on DDH introduction. It is a spectrum of condition which is related to the development of hip in infants and young children. It includes abnormal development of the acetabulum, and proximal femur, and mechanical instability of the hip joint. So what is the incidence of DDH? As per the IAP guidelines 2022, there is a spectrum which consists of mild instability to dislocation. Mild instability, which resolves spontaneously, corresponds to around 69.5%, while dislocation 4.5% per 1000. As per the CPG guidelines, they have told that the incidence is around 0 to 75% per 1000 live birth, and the incidence of true DDH around 0 to 2.6% per 1000 live birth. In as many as 37% of the patients, both the hips may be involved, both the hips may be dislocated. Among the unilateral cases, the left hip is affected more often than right. It may be related to the typical left occiput anterior fetal positioning, in which the left hip is forced into adduction against the mother's sacrum. So to discuss the types of dislocation, there are three types of dislocation, that is typical DDH, teratologic hip dysplasia, and neuromuscular dysplasia. Typical DDH, which generally occurs in otherwise healthy infants. Teratologic hip dysplasia, it is usually hello.
Yes, Meghna, continue.
Yes, ma'am.
Now
Yes.
we can start again. Huh?
Yes, ma'am. So types of dislocation, there are three types of dislocation, that is typical DDH, teratologic hip dysplasia, and neuromuscular hip dysplasia. Typical DDH, which generally occurs in otherwise healthy infants, a teratologic hip dysplasia is usually associated with various syndrome. Like this, in this, there's a case of Ehlers-Danlos syndrome, which presents with congenital hip dislocation, severe generalized joint hypermobility. A case of arthrogryposis, in which there is rigid deformities of all four limbs involving hip, could also be associated with Down syndrome. In the neuromuscular hip dysplasia, it occurs when there is a weakness and or spasticity in some or all of the hip muscle groups, which may be seen in spina bifida or cerebral palsy patients. So this is a recommendation which was given by this is a recommendation which was given by International Hip Registry. According to this, around
You're in mute, Meghna.
sorry, ma'am. According to the International Hip Dysplasia Registry, IHDR, it has recommended 6 different types of spectrum which is being seen in DDH. It includes dysplasia, subluxable, dislocatable, subluxation, reducible, and dislocation. So dysplasia is basically the abnormality of the shape of the hip joint, usually a shallow acetabulum, which is involving the anterior and superior margins. Subluxable, it is a hip with mild instability only. Dislocatable, it is a hip with instability where the femoral head is reduced at rest but can dislocate in other positions or with examination maneuvers. Subluxation, the femoral head is partially outside of the acetabulum, but still it remains in contact with the acetabulum. While the reducible, the hip is dislocated at rest, but the femoral head can be positioned into acetabulum with manipulation. While with dislocation, there is a complete loss of contact. So as per the CPG guidelines, what are the risk factors for DDH which was being given as a screening purpose? First includes breech presentation at any point after 36 weeks of pregnancy, irrespective of presentation at birth or mode of delivery. Or if there is any family history of DDH, including first degree or second degree relatives diagnosed with DDH. Or if there is any improper swaddling practices, or presence of hip instability at any previous clinical examination. A brief on breech presentation. Breech presentation is a major DDH risk factor, possibly because of the crowding of the fetus within the uterus. And among the 3 breech presentation, it is the frank breech which has the highest risk of chance as compared to the footling presentation. It has also been seen as per the recommendation by the CPG guidelines that girls are approximately 4 to 5 times more likely than boys to have DDH, and girls born breech have the highest risk, but only a female sex alone cannot be used as an indication for risk factor screening in the DDH surveillance guideline. The reason was given that females, because there is a transient increase in ligamentous laxity related to increased susceptibility of the females to the maternal hormone, there is a slight increase in the female being more prone as compared to males. Improper swaddling practices as per the CPG guidelines. Swaddling basically is a traditional practice of wrapping a baby in clothes or blankets that can tightly restrict limb movements. While swaddling has been shown to have several beneficial effects for the newborn, tight swaddling of the legs with the hips in extension and adduction can tighten the muscles around the hip joint and predispose to hip dislocation. So what are the risk factors which are not been included for DDH screening as per the CPG guidelines? So any of the factor like oligohydramnios, multiple pregnancy, foot deformities, asymmetric thigh or gluteal skin creases, hip clicks or torticollis, these risk factors which were historically been associated are not recommended by CPG guidelines because they have not found a good strong evidence of association associated with DDH. So as per the CPG guidelines, what if there is no risk factor present or if risk factor is present? If no risk factor is present, then baby can return to routine hip surveillance. But if one or more risk factor are present, then baby will require further imaging like USG or X-ray depending upon the age. Any abnormal image finding should prompt a referral. So the next question that comes is, what if the clinical examination is normal, but the baby is having risk factor? So as per the CPG guidelines, they say that if the baby is having risk factor, further evaluation must be done, and it should include ultrasound taken no earlier than 6 weeks for age of infants less than 14 weeks. So infants younger than 14 weeks should be screened after 6 weeks by ultrasound, or ultrasound or X-ray for infants 14 weeks to 6 months of age, or for older than 6 months we should go for X-ray. So again, referral if any of the radiological tests are abnormal. A bit on embryology and pathogenesis. In these 3 pictures, we can see the pathological changes of DDH, which occur as a spectrum. Basically, first the changes begins with the laxity of the hip joint capsule, which permits the femoral head to move out of the acetabulum. This movement results in eversion of the labrum and elongation of the ligamentum teres. There occurs elongation of the ligamentum teres, and eventually this elongation of ligamentum teres and eversion will prevent the relocation of the femoral head into the acetabulum. So in short, usually the hip joint forms by around 11 weeks, and the femoral head will grow at a faster rate than the acetabular cavity. So only 50% of the femoral head will be covered by the acetabular roof. During final 4 weeks of gestation, the hip is vulnerable to the mechanical adduction force. So any condition that limit fetal mobility like breech will accentuate the mechanical forces resulting in eccentric contact. So there occurs an abnormal ossification of the acetabulum and a shallow acetabulum develops. Also, there occurs hypertrophy of intra-articular structures with contractures in iliopsoas and hip adductors. False acetabulum form where femoral head contacts lateral wall of pelvis above true acetabulum. And this lack of contact will further prevent lack of contact between femoral head and acetabulum inhibits further normal development of hip joint. Clinical features. With what features the baby will present? So the spectrum could be instability on newborn examination, to subtle limited abduction in infant, to asymmetric gait in the toddler, or activity related pain in the adolescent, to osteoarthritis in adults. So this is a brief on discussion of unilateral or bilateral dislocation of hip and what is their presentation. Hip instability would be seen in both as per, it is discussed as per the age, like birth to 3 months, 3 to 12 months, and after the child begins to walk. So in first 3 months, if there is bilateral dislocation of hip, there won't be any asymmetric leg crease or any apparent shortening of the femur because it is bilateral. In unilateral, there would be apparent shortening of femur with asymmetric leg creases. Among 3 to 12 months of age, there would be limited hip abduction. There would be asymmetric shortening of femur. In the unilateral case, there would be asymmetry. After the child begins to walk, in bilateral dislocation of hip, that would be more prominent. Like we can see in this figure, excessive lordosis would be there. This is bilateral positive Clis test. This is like widening of the perineum occurs in the bilateral dislocation of hip and short thigh segments. So what are the clinical tests which are being included in CPG guidelines? The first is Barlow test. Barlow is a provocative test. The thigh is grasped loosely with the examiner's index and middle finger along the greater trochanter and thumb on the inner thigh. The hip is gently adducted and no downward pressure is applied, and the head is palpated to detect moving out of the back of the acetabulum. The examiner should not attempt to forcefully dislocate the femoral head. If the hip is dislocatable, the posterior movement and a palpable clunk may be detected as the femoral head exits the acetabulum. It has been found that the combination of Barlow and Ortolani maneuver has a specificity of around 98 to 99% to detect hip instability. The second is Ortolani test. Ortolani test, the test is performed by grasping the thigh loosely with the examiner's index and middle finger along the greater trochanter and the thumb on the inner thigh. From this adducted position, the hip is now gently abducted while lifting or pushing the trochanter anteriorly. Extreme abduction should be avoided as it decreases the sensitivity of the Ortolani maneuver. If the hip is dislocated, the Ortolani maneuver may reduce it, and it is again accompanied by a palpable clunk. The third one is Galazzi test. So this is performed with the infant being supine, hips flexed to 90 degrees, knees flexed, and feet flat on a level surface and side by side with the heels in opposition to the buttocks. In this position, the knees are normally at the same level. But if there is any unilateral dislocation, this side of the femoral head, it will be displaced posteriorly. So there would be an apparent shortening of the thigh. A positive Galazzi test, but it is not specific for DDH, as it could be seen in other cases also, like hemihypertrophy, femoral hypoplasia, or coxa vara. The other one is limited hip abduction, LHA test. The clinical assessment of limited hip abduction is made when the baby is made supine with both the hips flexed to 90 degrees and full abduction of the hip joint is attempted. Any block to full abduction, which we can see in this figure, any block to full abduction from the horizontal is considered to be positive if there is limitation of more than 20 degrees as compared to the opposite hip in unilateral case, or if it is around 60 degrees of hip abduction, then it is in the, if it is less than 60 degrees of hip abduction on each side, then it is a bilateral case. So what is the CPG guidelines word on these clinical tests? So they say that Barlow and Ortolani tests are critical clinical tests to determine instability and reducibility in the infant hip, and both these tests are most effective in early infancy, up to 3 months of age, since they tend to become negative as the baby grows. Unilateral limitation of hip abduction beyond 8 weeks of age is an important clinical indicator of pathologic DDH with high specificity around 90% and moderate sensitivity of around 70%. So this is the recommendation which is being given, as we have discussed, in less than 3 months to prefer Ortolani and Barlow. In 3 months, 14 weeks to 6 months, limited hip abduction and Galazzi sign, and more than 6 months, similar also if the child is walking, to consider limb. So imaging guidelines, what does ultrasound and X-ray findings are? As per the CPG guidelines, USG, it is also a primary imaging technique for assessing the morphology and stability of the infant hip and can be used as a screening tool anytime from birth to 6 months of age, provided that quality ultrasound is available. It is helpful in confirming physical examination findings and evaluating the infants with risk factors who have normal examination findings. Beyond 6 months of age, the appearance and growth of the ossification center of the femoral head begins to obscure. So after 6 months, USG is not of much use. So here there are some findings that we see in the USG, which are like alpha angle and beta angle. Alpha angle, which is measured from the, as we can see in this figure, alpha angle is measured from the lateral wall of the ilium and the bony roof line. The beta angle, it is the angle which is formed by the lateral wall of the ilium and cartilaginous roof line. So these two angles are being used, this beta angle and alpha angle, to classify the DDH. So basically the alpha angle reflects the depth of the bony acetabular roof and beta angle reflects the cartilaginous coverage. Normally, alpha angle is more than 60 degree and beta angle less than 55 degree. In the case of acetabular dysplasia, angle would be less than 60 degree alpha angle and beta angle would be more than 55 degree in femoral head subluxation. Like this is one USG, coronal USG of the hip, which demonstrates femoral head, which is having less than 50% coverage by the bony acetabulum, which suggests that there is dislocation of the hip. Among the X-ray CPG guidelines, the earliest that an X-ray can be used as a screening tool as per these guidelines are at 14 weeks of age. The recommended time to transition from ultrasound to X-ray imaging is between 4 to 6 months of age, as this is when the femoral head ossific nucleus typically becomes visibly radiographically. As well as the International Hip Dysplasia Institute IHDI classification. It is a reliable radiographic system to quantify the DDH severity. This is the same that we have discussed, the 6 points: dysplasia to dislocation. Also, they recommend a single anteroposterior AP pelvis radiograph is required for DDH screening without the need of a frog lateral radiograph. So in X-ray, there are some lines which are being discussed, that is Hilgerian line. This is a horizontal line through the upper margin of the radiolucent triradiate cartilage. The Perkins line, which is a vertical line which is drawn from most lateral ossified margin of the roof of the acetabulum and perpendicular to Hilgerian line. So this is our normal picture and this is a DDH. So what is the difference in this? In the normal hip, the medial end of the ossified upper femoral metaphysis. Just one second. This part will lie medial to Perkins line. This is the Perkins line and it will lie median to the Perkins line and inferior to the Hilgerian line. But if the hip is subluxated, it will lie lateral to the Perkins line and superior to the Hilgerian's line. The other one is Shenton line. It is drawn from the medial border of the femoral neck to the superior border of the obturator foramen. In the normal right hip, in the normal right hip, it is a continuous contour, but that this we can see, whereas in the hip with DDH, it would be disrupted. Now, other one is acetabular index. Acetabular index, it is an angle which is formed between the Hungarian line and a tangential line to the lateral ossific margin of the roof of the acetabulum. The acetabular index changes with axial and sagittal plane rotation, and it's helpful in measuring the development of osseous roof of the acetabulum. In the newborn, the acetabular index must be over 40 degrees to be significantly abnormal. So the radiographic findings which are consistent with DDH are lateral and superior positioning of the ossified portion of the femoral head and neck, increased acetabular index, delayed appearance of the femoral ossific nucleus on the involved side, or asymmetric sizes of the femoral ossific nuclei. As we can see in this X-ray, it shows the similar findings. So the recommendation is, if the baby is younger than 6 weeks, to do ultrasound at 6 weeks of age. If ultrasound immediately not possible, we can get an X-ray done at 14 weeks of age. Between 6 to 14 weeks, again ultrasound at the earliest, and X-ray could be done at 14 weeks of age. Between 14 weeks to 6 months, ultrasound or anterior-posterior pelvis X-ray depending on the availability. Older than 6 months, X-ray is being preferred. So now the CPG guidelines as per the age. So they have recommended 4 age group: age less than 6 weeks, age between 6 to 14 weeks, age 14 weeks to 6 months, and older than 6 months. So what if the baby presents to us younger than 6 weeks? So what are the clinical tests which are being recommended? They are Ortolani and Barlow test. So what if there is normal clinical examination? If normal clinical examination, the babies must undergo risk factor screening. And if risk factor screening is present, we should consider additional imaging before 6 months of age. If there is any inconclusive examination, better to refer immediately to pediatric orthopedic surgeon. If Ortolani test is positive, again we have to refer the baby to pediatric orthopedic surgeon. What if we have done the Barlow and Ortolani test, but only Barlow test is positive? So in the condition with positive Barlow test, they say that baby does not require immediate referral to orthopedics, as these hips may resolve spontaneously, but as well as ideally to perform ultrasound at 6 weeks of age. If at risk for loss to follow up, USG can be obtained right at the time the baby has presented to us. If quality USG is not available, an AP pelvis X-ray should be scheduled at 14 weeks. If imaging is normal, baby can return to routine hip surveillance. Alternatively, if the first imaging is normal, an examiner can choose to schedule an additional follow-up X-ray at 6 months. This additional follow-up imaging for a baby with an initial positive Barlow test is recommended, particularly if the risk factors are also present. Any abnormal findings in the USG at 6 weeks or X-ray at 14 weeks should prompt a referral. Now, baby between 6 to 14 weeks. In this age group, again, the clinical tests recommended include Ortolani and Barlow test. So there are 3 scenarios which can come to us. There is normal clinical examination, positive Ortolani and or positive Barlow test, or inconclusive or uncertain clinical examination. If normal clinical examination, the baby must undergo risk factor screening. If inconclusive, refer to orthopedic surgeon. If positive Ortolani and or Barlow test, again to refer to orthopedic surgeon. Now, when if the baby presents between 14 weeks to 6 months, the clinical tests which have been recommended are limited hip abduction and leg length discrepancy test. Again, the three conditions it comes, whether it is normal, positive or inconclusive. Normal, again to undergo risk factor screening. Any of the sign, if inconclusive, refer to orthopedic surgeon. Positive, again we have to refer to an orthopedic surgeon. In case if baby is older than 6 months, here the clinical test along with limited hip abduction and limb length discrepancy, if the baby is walking, to include limb also as a clinical test. If normal clinical examination, undergo risk factor screening. Inconclusive, refer to orthopedic surgeon. Positive, again we have to refer. Any of the signs are positive. So this is the same recommendation guidelines that we have discussed. According to this CPG guidelines, they say it is not an urgent referral for orthopedics to if there is only a Barlow test is positive less than 6 weeks. Referral is not required if there's a normal physical examination and no risk factors are present and normal imaging findings are there. So this is the same that we have discussed. Same the protocol that we have discussed earlier. So the limitation of these guidelines are, first, the patients, the families were not included in this development process. Second, rural areas was not being considered as the data couldn't be collected from that place. And third, the management of the DDH was not being included in these guidelines. As per the IAP guidelines, a brief on the management purpose that I want to discuss is, they recommend that within 0 to 6 months of age, they recommend public harness, 6 to 18 months, closed reduction or open reduction, 1.5 to 2.5 years, open reduction, 2.5 to 8 years, open reduction with acetabuloplasty. If presenting more than 8 years, if it is bilateral, they say do not touch. If unilateral, can be operated with guarded prognosis. So to summarize, here I would be ending that early diagnosis and referral is a key to improve long-term outcomes in children with DDH, and always examine the hips during all the well baby or immunization visit to catch signs of DDH early. So here I would end. Thank you all.
Thank you, Meghna, for the clear presentation. I think there is a question in the chat regarding what is the CLISIC test. So can you explain? Do you know?
Yes, ma'am. Yes, ma'am.
CLISIC test. Yes.
So basically, in CLISIC test, we place our index finger on the anterior superior iliac spine and middle finger on the greater trochanter, and an imaginary line which passes through like above the umbilicus. If we consider these 2 points like anterior superior iliac spine and middle finger on the greater trochanter, then when we make a tangential line that will go above the umbilicus in a normal baby. But if the line passes below the umbilicus, the hip is dislocated. As we have discussed, in bilateral dislocation of hip, it is of great use.
Yes. Yes, well answered. Normally when we have a confusion, because when you have a bilateral hip, many of the classical, both the sides are dislocated. Many of the classical signs and asymmetry may not be seen. So this may be a simple test that you can do. So you just take the points between the anterior superior iliac spine and the greater trochanter and draw an imaginary line up to the umbilicus. Normally it should be at the or above the level of umbilicus. If that line is going below, then it means it is a dislocated hip. So very good presentation, Meghna. And just before we go to the expert, so I think all of us have been, as neonatologists, practicing screening for hip dislocation, especially for high risk, and hip examination should be a part of the routine before discharge from the hospital. So one of the things is the examination should be done gently, because especially when you're doing the Barlow test, we should repeated examination of the hip and aggressive Barlow testing. You should not be subluxating a hip which is normal. So it should be done gently and not in an aggressive manner. And this Barlow and Ortolani has limited the use after 3 months of age. Then you will have to look for other signs, like she said, like the limb length discrepancy using the Galassi sign or hip abduction. Normally, the hip abduction on unilaterally, if it is less than 60%, you're keeping the hip at 90%, and if you're not able to abduct less than 60%, or there is a difference of more than 20% between both the sides, you will call it a limiter. So even when a child, you have missed the newborn screening, when the child is coming to follow up in the well baby clinic or immunization clinic, always take an opportunity, especially if the risk factor is there, to look at the hips. And investigation, of course, is many times operator dependent, especially the ultrasound. You need an expert to interpret the angles and the lines. So that again, you need a good radiology backup for ultrasound hip. X-ray, of course, can be done, but may not be of limited use in the neonatal period. And you may have to wait. Classically, we were said 6 months, but you can as early as 14 weeks also. The X-ray may be helpful for detection of a dislocated hip. So with that, I hand over the mic to Dr. Vinod.
Once again, Radhika, and this Ortolani and Barlow's test, the American Academy of Pediatrics recent article, they have suggested not to do Barlow's test, but this suggestion is good. Even if you're doing the Barlow's test, don't push posteriorly. Previously, we are teaching the students like adducting and then pushing posteriorly. So if you avoid pushing posteriorly, this subluxatable becoming dislocated can be prevented.
Yes.
Sorry.
Yes, sir. Thank you, sir. So I invite Dr. Vinod Krishnan to give his expert views on how he has been seeing and managing patients with developmental dysplasia of the hip.
Thank you, Dr. Radhika, for the kind invitation to attend this session. Actually, this is for any pediatric orthopedic surgeon, this is a very important topic. And most important thing I would definitely emphasize is neonatological clinical examination. That is the most important examination to be done in a newborn period. Basically, what you need is some warm hands. You need some time. You need to spend some time with the baby, and you should be very gentle, because the feeling of clunk, I think every neonatology fellow or those who are working in a pediatrician should at least get a feeling of what the clunk or a click is. These two are totally different. So if you are very gentle, if you have warm hands, and if you have time, if you examine, and once you get that clunk feel, you will never miss this finding, because I would rely on the neonatologist to pick up DDH rather than the orthopedic surgeon. A junior orthopedic surgeon, I imagine he'll never pick up DDH because he doesn't have time. He just comes, he just will have a hand rub in his hands and then go and touch a baby. Immediately there will be some muscle spasm, the baby starts yelling, and you will not get the actual clinical imaging. So again, Ortolani or Barlow is the key clinical examination findings to detect DDH. And even if it is normal, especially if there are risk factors, you go on and examine. That is why this clinical screening program is actually coordinated along with the vaccination schedule, so that you don't miss 6, 10, 14. So even if you miss at 6 weeks, you can again do at 6 weeks or 10 weeks or 14 weeks, because the prognosis of hip dislocation, the treatment, if it is done before 6 months, it is almost excellent. You can get near normal hips in almost all of the cases. Once the diagnosis is delayed, especially if it is walking age, then the complications are very high. So we would prefer to detect hip dislocation and treat as early as possible. Now, the key imaging modality definitely is ultrasound, because it avoids radiation and it can clearly show the femoral head. The cartilaginous femoral head obviously is not visible in the X-ray, but in the ultrasound, if properly done, the acetabulum and the cartilage morphology we can clearly delineate. So if given a chance, ultrasound is a key imaging modality in DDH. The only problem is expertise. I've seen senior radiologists not doing the pictures. There are two methods actually, Graph's method and Harksky's method for quantifying DDH. In the literature, they have given clear ideas how to do the imaging. They will not allow us to like measure the angles if the images are not proper. So every bony landmark should be in a proper position to make the imaging. That is why you can have false positive and false negative imaging ultrasound this thing. So it is entirely operative dependent. Now, any ultrasound before 6 weeks may be inaccurate because infant before 6 weeks and unit, they have all the physiological instabilities which usually resolve without any treatment. So there are screening programs in the Western where the incidence of DDH is high because they screen every baby in the newborn period and at 6 weeks with an ultrasound. Every baby, that is a European guideline. So because the incidence of DDH is so high, ours, I don't think it is that much needed, but risk factors, definitely. Any doubt in clinical examination or any positive clinical findings, you do an ultrasound. Now, if ultrasound is not available, or you cannot rely on a good ultrasoundologist to do this, then probably an X-ray. Because with the newer ISDI, that is the Institute of Hip Dysplasia Institute, their criteria, even at 14 weeks, you can diagnose DDH with their criteria. And the key point in DDH is you need to follow, because most of the time neonatological hip instability may not need treatment, but every time you see a baby, you repeat the examination. Any doubt, you do imaging and then refer to an appropriate specialist. As I said, before 6 months, the incidence of complications are very less. Now, if you do an ultrasound before the age of 6 weeks, and if you do finds, you get some findings, most of the time, those findings may not give an indication for treatment, because unnecessary treatment with Pavlik harness can also cause complications. So that is why 6 weeks will be the ideal age to do an ultrasound if there is any equivocal clinical findings. If abnormal clinical findings are there, you go ahead and do it any age, no issues. And after walking age, that is means maybe at 1.5 years or 2 years, the complexity. So before 6 months, we can treat with the Pavlik harness. Before probably 1 year or 18 months, we can treat with closed reduction. That means without any operative procedures. We just manipulate under anesthesia. We'll be able to get the hip back into position. But after 1.5 years, the complexity of treatment becomes more. We may have to do open reduction. We may have to do femoral osteotomy. We may have to do pelvic osteotomy, and the chance of complications are less. And sometimes, even if you do a good open reduction and all these procedures, there are situations where there are secondary instabilities. There are problems with growth thrust. The proximal femur has a very delicate blood supply. So once you do an open reduction, or once you do a tight reduction of the hip joint, the blood supply can be destroyed, and that can cause long-term problems with the growth of the proximal femur. That is why these are all the incidence of complications are more when the age of the child is more. So above 1 year, the chance of complications are really more. And all these children, even if you are treated, even if the DDH is treated satisfactorily with a Pavlik harness, they all need to be followed up till skeletal maturity, 14 years. The orthopedic surgeon should monitor them for till 14 years of age to find out if they develop complications. Because problems with growth thrust, we may not pick it up in the first few years of X-rays. Maybe at 7 years or 10 years, once you take an X-ray, you may find that the femur head is in valgus, or femur head is in varus, or the acetabulum is not like a congruent acetabulum. They also will need a corrective procedures. So all said and done, clinical examination and ultrasound is a gold standard imaging. Follow-up imaging may also be needed, even if the initial ultrasound is abnormal. We have seen cases where after 4 weeks, once you do a follow-up ultrasound, the hip morphology improves. So treatment may not be needed in all cases of an abnormal ultrasound findings. And as I said, as she has said nicely, swaddling is typically the most important cause for progression of the hip dysplasia, because hip dislocation, the DDH, classical DDH, is a pure positional deformity. It happens only because of faulty intrauterine position and even postnatal. So even if there is a mild acetabular dysplasia, tight swaddling can make into a full-blown dislocated DDH. Whereas in a teratological dislocation, it is an abnormal hip. Even when the baby was made, even at the age of 3 months or 4 months, there was no hip at all. So that is why it is called a teratological dislocation. Most of the cases, they need surgical treatment for teratological dislocation because it is a complicated anatomy. Whereas most of the cases of DDH, if diagnosed early, can be treated by non-operative methods without significant complications. Probably that is
yeah, one or two questions are there. One is, I think you have covered most of them. Any associated prognostic factors? So what will one would be the time of detection probably?
Yeah, the most important will be the time of detection. And the second thing is what procedure you have done to get the hip back into position. Is it Pavlik harness? Is it closed reduction? Or is it operative interference? So the degree of the prognosis becomes bleak when the degree of treatment complexity becomes more. So that is indirectly related to the age of the patient at the time of diagnosis. So the single most important prognostic factor, I would say, is the age at presentation and the ability of the surgeon to get the hip back into position without significant problems.
Do you have more difficulty in the syndromic cases or the correction?
Syndromic cases, the problem is most often the Pavlik harness won't work because most of the time it is bilateral or it may be secondary to some collagen disorders or sometimes even neuromuscular. So most often they will be bilateral, there will be contractures and invariably will need surgical procedures. And second thing is most of the time the primary problem persists. So secondary instability again is a problem with syndromic cases. So even if you have put it back, it can go out again. The chance of recurrence is more in syndromic cases.
Okay. There is one more question. What is the sensitivity and specificity of the Barlow test? So is it very sensitive?
Yeah, of course. In an abnormal hip, even both Ortolani and Barlow, the sensitivity is more than 90%. Actually, it is a very specific and sensitive test. Only that it needs to be properly performed. When I was in Australia, there was
observer dependent.
Yeah, it's purely observer. As I said, it cannot be done in when you are coming in a rush. You just want to finish the rounds and you are just doing an Ortolani and Barlow. It will not happen. You need to spend some time. You need to be. You need to have some warm hands, and the baby should be kept warm. It should be relaxed. Probably after a feeding this thing, a well-fed baby will be an ideal candidate to do a Ortolani or Barlow. Definitely more than 90%. I would say more than 90%.
Okay, very nice. So, and you would generally, the cases that you have seen, how do they do well on? Do they do well on follow-up? The ones with Pavlik harness alone.
Yeah, Pavlik harness alone. I have had only 1 or 2 situations where the hip was not reduced. That happens usually in a bilateral. What we see in a bilateral hip dislocation. Some people say it is generally a contraindication to do Pavlik harness, but still I treat with Pavlik harness. What I find is one of the hip goes into the acetabulum. Probably the other one becomes persistently dislocated. But otherwise, in unilateral hip dislocations, if treated before 14 weeks, Pavlik harness is still, I think, the best method to treat. Even though there are problems, yes, Pavlik harness treatment can cause complications, but still is one of the most effective way to treat hip DDH before 4 months, or even I have tried up till 6 months without much problems.
That total in the old school training of that triple diaper and keeping the leg abducted is totally gone now. No, that is not there.
Totally gone. Yeah. So mild cases of hip instability, maybe triple diapers can put the hip back, the femoral head back into the joint. But the key thing is any treatment. You see, you can do anything. If it works, it is good. But the thing is, you need to follow. Even if you have done a Pavlik harness, you need to do clinical examination in the Pavlik harness to confirm that the hip has gone back into the joint. If there is any doubt, I usually do an ultrasound at the end of 1 week or 2 weeks to confirm that the femoral head has gone back into the joint. If even if after 2 or 3 weeks of Pavlik harness application, the femoral head is still dislocated, don't continue with that method. You try something else. So that is what you can try a double diaper or triple diaper, but you need to make sure that it is working. As I said, just sometimes a simple abducted, flexed and abducted position of the hip alone will get the femoral head back into the joint. Whatever you do, you need to confirm that the femoral head is in good position after your treatment has started.
Are there any further questions?
No, one thing I think Meghna, Mr. Dara, I didn't hear it clearly is this important associated history. One is the female sex, second is family history. According to the AAP publication also there. Yeah, okay. They strongly suggested family history is the most important indicating factor. Second thing about this AAP article, recent publication, they have not recommended Barlow at all. Because Barlow, they say by doing Barlow unnecessarily, you may dislocate a subluxatable hip. So I don't know whether, but the Indian, this publication, they clearly said you can do it, but not push it posteriorly. Maybe that is okay. And the other thing Vinod said, this is very true. In India, we are keeping the babies, usually taking the babies on the side, where that prevents that helps really in the formation of the acetabulum cavity and femoral head rotating in that, isn't it? In the West, the tight swaddling, that is the worst thing. They swaddle the baby so tightly, there is no movement at all. Isn't it, Dr. Vinod?
Yeah, so even I think the CPG group, especially Dr. Alaric Arujis, he is a pediatric orthopedic surgeon in this group. He has devised a special swaddling method. If you because in the Western situation, the climate is the risk factor. So they have very cold climate, and then swaddling is essential. And as Megha has mentioned, there are other positive effects for swaddling. But in the Indian scenario, we don't usually swaddle the babies so tightly. So as Sir said, so the hips have a tendency to go into flexion and abduction in our babies. So that is probably why we don't see hip dysplasia as common as in Western situation. Tight swaddling is not that common in our country.
Yeah.
So I think that is a good presentation and discussion. If there are no further questions, I think we can conclude the meeting. I once again want to thank Dr. Vinod Krishnan because for last minute invite and he has readily agreed, and we are having Onam time in Kerala. It's a festive season. In spite of that, thank you so much for sharing your experience with us. And once again, congratulations to Meghna for the very well done presentation. Thank you all. Thank you all for the patient listening. And thank you, PMC Nair sir, a senior most professor, for attending the meeting. Thank you.
Thank you and good night. Thank you. Thank you, sir.
Okay, good night. Good night. Thank you.